According to the biblical story, human beings are created in the image of God, which would suggest that human beings have the ability, as God does, of forming attachments. Attachments meaning things that they value, things that they love, things that they cathect, things that they invest themselves in so highly that when they lose that thing, it feels as though they've lost a part of themselves. Of course, the greatest forms of attachment are attachments with those individuals, those human beings that we love, especially our family members. When we invest ourselves in them, we form a strong attachment, and when that attachment is broken, for whatever reason, we engage in certain kinds of behaviors to try to reestablish the attachment. There's a vast repertoire of attachment behaviors that people can engage in, but Worden in a 1991 paper described this repertoire of behaviors under 4 general categories: the emotional response, various physical sensations, altered cognitions, as in different ways of thinking, and certain kinds of physical behaviors. Looking first at some of the varieties in emotional responses, and recognizing that grief fundamentally is an emotional response to loss. The expression of this grief can include things like sadness, sorrow, fatigue, depression, sometimes paradoxically, relief, shock, anger, guilt, and anxiety. Grief behaviors frequently have a similar profile to those found in people suffering from depression. Although grief and depression do share a number of similar aspects, including sleep and appetite disturbances and intense sadness, these behaviors are only evident for a short time in a grief reaction. In addition to that, those experiencing a grief reaction do not always experience the loss of self-esteem that is commonly found in most people who are clinically depressed. However, intense feelings of loneliness and isolation following the death of a loved one may become so overwhelming that the bereaved may withdraw from social contact, thereby isolating themselves from support. Such reactive depression following a significant loss is not abnormal, and it usually dissipates over the first year of bereavement. Anger is another frequently experienced emotion following loss, and it's often very confusing for the person who is bereaved. The anger may be directed at the deceased for leaving the bereaved alone, or perhaps for not getting treatment earlier, or something like that. Or it may result from a sense of frustration that the bereaved couldn't prevent the death. If the anger is not addressed, complications in the grieving process may arise. There's a risk that the anger will be directed towards others through attributing blame, or perhaps turned inwards and become a long-standing depression. A second category of responses includes physical sensations. Grief not only elicits emotional disturbances, but also physical symptoms such as tight feelings in the throat and the chest, oversensitivity to noise, breathlessness, a sense of suffocation, muscular weakness, a lack of energy. These sensations are considered to be a normal component of grief. Usually they're transitory, but on occasion they may become of such concern to the bereaved that they warrant clinical intervention. A bereaved person may go to the emergency room with those symptoms, believing that he or she is having a heart attack. Occasionally, physical health may be seriously impaired, and there's growing evidence that indicates that recently bereaved people are more vulnerable to illness than those who are not. Another category of responses are cognitive responses. Often new thought patterns occur in the early stages of mourning, but they usually disappear after a short period. But persistent, maladaptive thoughts may trigger feelings that can lead to depression or anxiety. Disbelief is often the initial cognitive reaction to the news of a death, especially if the death was sudden, and the bereaved person frequently will say things like, "I can't believe it," or acts as though it hasn't happened. Although this response is usually transitory, it can persist, and if it does, then it can become a chronic kind of denial where the bereaved does not accept the death. Other cognitive responses include feelings of confusion, difficulty organizing thoughts, and preoccupation with the deceased person, which may invoke intrusive thoughts of how the deceased died, going over and over and over in their minds what they might have experienced in the moments before death. The bereaved person may even report a sense of presence of the deceased person and may think that the deceased is still around, sitting in his or her favorite chair or lying next to them in the bed. And these can be very powerful cognitive responses, so much so that it can result in auditory and or visual hallucinations. Some people find these experiences comforting and think that it's just great that they have this continuing sense of the presence of the bereaved. Sometimes they will assign spiritual or metaphysical explanations to the phenomena, which can help them cope with the loss. But other people may find them deeply disturbing and wonder if they are losing their mind. In the category of behaviors, there are a number of different behaviors associated with grief that may be of concern to the bereaved person, but they generally subside over time. There are complications in the grieving process, or a depressive disorder may be indicated, if the behaviors impede a person's ability to function. The most commonly reported behaviors include disturbances in sleep, altered appetite, either overeating or undereating, absent-mindedness, social withdrawal, dreaming of the deceased, avoidance behavior, in which the bereaved person may go to great lengths to avoid any situations or objects that remind them of the deceased. We've seen this often in pastoral care, where people no longer want to come to church because they have a multi-decadal memory of sitting in the pews with their loved one who is no longer there, and they feel the grief and bereavement much more acutely during those times. So they separate themselves from the worshiping community at a time when they really need that support the most. Additionally, the bereaved may feel restless, breathless, find themselves searching or calling out for the deceased. Another behavior often associated with grief is crying, a response which is believed to relieve emotional stress, and we don't really know just why it happens. It's one of those unexplainable sort of things about human beings. But once again, as the Bible says, we were made in the image of God, and in the person of Jesus, God wept. There are a number of factors that determine the intensity and the emotional response to loss. Some of them include the importance that is attributed to the loss, the circumstances of the death, and the availability and the utilization of support networks. The length and the intensity of the grief experienced by the bereaved varies depending on the nature of the relationship and the degree of attachment. If, for example, the person was not terribly well known, then obviously the grief is less. On the other hand, if this person was very intensely known and highly important to the individual who is grieving, then there's greater grief. That's sort of obvious. But one of the things that's not so obvious is that the strength and existence of ambivalence in the relationship has a tremendous impact on the intensity of the grief. Relationships that include a high degree of ambivalence, like an unhappy marriage, or conflicts with a child who maybe hasn't been doing very well growing up, or those sorts of issues, usually lead to an extensive feeling of guilt, which is often accompanied by anger. The mode of death also impacts the degree of grief experienced. Worden categorized death into 4 groups: natural, accidental, suicidal, and homicidal. Sudden and accidental deaths are likely to have the greatest impact on grief. Morbidity and mortality are very much influenced by grief. Grief exacerbates not only physical morbidity, but psychiatric morbidity as well, particularly in cases that are associated with the loss of a spouse. Studies have found that bereaved individuals suffer from more depressive symptoms during the first year after the loss than non-bereaved controls. The young are more susceptible to physical distress and drug taking for symptom relief. Further, following the death of a spouse, there's an increase in symptoms such as headaches, trembling, dizziness, heart palpitations, and gastrointestinal symptoms. As far back as the 19th century, physicians who were working with cancer patients frequently reported that severe emotional loss and grief were associated with cancer as a precursor. Research in psychoneuroimmunology in more recent times has reactivated interest in the connection, and it provides a convincing background for the mechanism as to how this might take place. Studies strongly suggest that stress, through neuroimmune modulatory mechanisms, can significantly affect the appearance and progression of mammary cancer. Although the difficulty of measuring stress makes it difficult to demonstrate a tangible relationship between stress and breast cancer, studies reveal that stress is related to breast cancer in various ways. For example, a study by Biondi and his colleagues investigated the case of a 45-year-old woman who had a moderate genetic familial risk of mammary cancer, but was clear at the time of initial examination. The woman's affection for her only child compensated for inadequacies in her marriage, which had become increasingly unstable. The child died in a traumatic accident at home while she was near him but unable to help. The patient developed long-lasting intense grief, despair, and hopelessness, and developed symptoms of breast cancer 3 years after the loss of her child. Although aware that stress does not necessarily create cancer, Biondi suggested that in this case the stress of unresolved grief could have contributed to the cancer by activation of a latent neoplasia or possibly by impairing immunocompetence during a critical life phase. So it's not just one simple causative mechanism, but an association of several. Further support was provided by Kemeny and colleagues who conducted a study to investigate whether immune changes relevant to HIV progression occurred in 39 HIV seropositive men after the death of their intimate partner. They compared the immunological parameters from blood samples drawn before and within 1 year after the death of the partner in the bereaved group, and over an equivalent time period in a controlled non-bereaved group. They found evidence to suggest that the death of an intimate partner in HIV-positive men is associated with immune changes that are relevant to HIV progression. This study confirms that the death of an intimate partner can adversely affect immune function and promote the progress of illness. If unresolved grief can exacerbate health problems, the question that begs to be asked is whether grief counseling can reduce the incidence of health problems following intense grief. A general model of psychosomatics assumes that inhibiting or holding back one's thoughts, feelings, and behaviors is associated with long-term stress and disease. It seems that actively confronting upsetting experiences through writing or talking them out can increase measures of cellular immune system function and reduce health center visits. Hence, externalizing traumatic experiences is physically beneficial and may serve as a preventative treatment for health problems. The implications are that grief counseling, which encourages disclosure of pain, may prevent future health problems. We talk about grief work, or the work that a bereaved person has to do in order to adapt to loss. This is technically referred to as mourning. And it is a process. It's not a state of mind, but a process. And as in any process, work is done so that the process can proceed to a successful finalization. According to Worden, there are 4 tasks to mourning which may take place in any order. Task 1 is accepting the reality of the loss. I would suggest that you pause this podcast for a moment and read through this material. The second task is to work through the pain of the grief, allowing oneself to feel the pain rather than suppressing it. And once again, I would suggest you pause the podcast so that you can read through the material on the slide. The third task is to adjust to an environment in which the deceased is missing. There's a whole lot of change that has to take place in order to arrive at this being okay with a new normal. And once again, I would suggest you pause the podcast and read through this material. The fourth task is to emotionally relocate the deceased and to move on with life. Emotional relocation means that the bereaved forms a different kind of relationship with the deceased than that which has taken place in life. Obviously, the deceased is deceased. It can't continue like it was. On the other hand, the bereaved person doesn't want to completely let go of all memories and emotions associated with the deceased. So there needs to come a new kind of position that the deceased person can occupy that enables the formation of a new kind of normal so that the bereaved person can get on with their life and begin to form new attachments and and form new memories. Most people are able to work through the range of reactions that follow a death of someone that they love, and able to do that pretty much on their own. However, some people need some help, and this is the place where counseling comes in to help people resolve their normal grief. Most of this is about helping the person who is grieving to normalize the feelings that they're having. Oftentimes people think that there's something wrong with them because they feel the way that they do, and that they're the only person who feels that way. And so counseling can help them to realize that they are having normal reactions to a very abnormal experience. I suggest again that you pause this slide and read through the research of Worden in his 1991 paper as it's summarized here on this slide. Normal mourning, normal grief, is a painful enough experience that a lot of people think that when they're going through normal mourning, they are really going through abnormal mourning. In most cases they're not, but in some cases normal grief turns into complicated or abnormal grief. And then you have an experience called complicated mourning. And this is actually recognized as an abnormal grief reaction in DSM-4 from the American Psychological Association, referred to as complicated bereavement. I would suggest again that you pause this podcast and read through the 3 paragraphs presented on this slide and get a sense of what complicated mourning looks like and some of the reasons why complicated mourning can grow out of normal bereavement. This slide also continues a discussion on complicated mourning, but it adds something somewhat interesting that you might want to look into in a little more detail, and that is the idea of post-abortion distress. Diagnostic and Statistical Manual doesn't recognize post-abortion syndrome, but other investigators realize that that is, in fact, for many women, a traumatic experience, and it closely matches the diagnostic criteria for post-traumatic stress disorder. So again, I would suggest pausing the podcast and reading through the material on this slide. Therapy for complicated grief revolves around the goal of identifying difficulties that are preventing the individual from completing the task of mourning, and then helping the person to work through that stuff so that they do in fact come out the other side with a different kind of relationship with the one who is lost, and the ability to go on and live their lives. If the therapist believes that this death has been complicated by the mourner's inability to deal with previous deaths, then therapy might include going back and including a look at how the bereaved person has dealt with death in their life story. There are 3 kinds of grief that are particularly difficult. One is the grief following suicide. Another is the grief that parents feel following the loss of a child. And the third category is the grieving of adolescents who usually don't quite know what to do with the experience of grief and loss and tend to act it out rather than feel it. This first paragraph takes a look at the issues surrounding those who are survivors or those who are left behind when someone commits suicide. And survivors of suicide have been found to experience a severe form of bereavement that is different both quantitatively and qualitatively from other kinds of bereavement. Also, parents who survive the sudden death of a child experience a unique kind of grief. There are some therapeutic interventions that have proven helpful in both of these cases, providing information to the survivors about the death. Sometimes people just plain don't want to know, but other times to find out exactly how the person committed suicide or what exactly was the cause of death are things that the person really wants to know later, even though they may not want to know at the time. Also, an opportunity to view the body or to view photographs of the body can be helpful in helping the bereaved to complete their grief work. Getting the bereaved into a support group that is dedicated to helping those who are grieving the loss of someone through suicide, or parents who are working through the death of a child. Support groups can be really helpful. And they also will want to know things about how likely is it that this is going to happen again. If we lost one child from SIDS, for example, how likely is it that we would lose another? If one family member committed suicide, how likely is it that this is going to plague our family? Are there any statistics, any science on that? People need to know. And as I said, adolescent bereavement frequently differs from the bereavement of adults. It's common that when an adolescent is confronted with these issues and they have no previous experience to draw on to help them cope with the feelings of rage and loneliness, disbelief and guilt that accompany loss. And so they may not think that these things are going to get better. They may think that this is going to be the permanent state of affairs from now on, which would lead them to a deeper kind of depression and maybe even some dangerous action. Also, don't forget that adolescents frequently express their feelings through behaviors rather than emotions. So one of the interventions suggested includes careful questioning of the adolescent griever to encourage the individual to express their emotions. You can't just take them saying, "Oh, I'm okay," as proof that they really are okay. They need support for the legitimacy of their feelings, and involvement in a support group specifically for adolescents going through bereavement is tremendously helpful. Mourning is considered to be complete when the person is able to experience pleasures, take on new roles, look forward to new events, and when memories of the deceased no longer evoke physical responses of sorrow and pain, although occasional feelings of sadness may remain. I think it's pretty important to keep this definition of the resolution of grief in mind. This is what we work towards, and when this isn't happening, more grief work is necessary. Bereavement is a complex issue with lots of emotional and behavioral impacts. Individuals experiencing grief go through a wide range of reactions, and research has indicated that grief can have an impact on morbidity and mortality. The model of the grief process presented by Worden in his 1991 paper discussed here provides a comprehensive framework around which counseling and therapy can be structured to help individuals to satisfactorily resolve their grief.